Thank you, Nick. Thank you, Trudy. And thank you for being here. Yes, I'm going to talk about guidelines, but I'm going to focus on the differences between the HRS, if I may call them that, and the ESC, HRS 2017, ESC 2018. So I have a few conflicts of interest to declare. The first paragraph is, I think, not really important, but the second one is. So I was on the task force for the ESC guidelines, which certainly biases me. And I was a reviewer of the HRS guidelines. And finally, any commentary like this is bound to be personal, and you may not agree with anything I say. Now, the obvious thing is the US system is more complicated, but probably better. In class of recommendation, there are two class 3s with the US system. That is, no benefit and harm. ESC doesn't separate. They put them in the same category. I think this is worthy to make the separation. And in levels of evidence, the US uses randomized controlled trials to separate from non-randomized trials, which also seems to me logical. In level of evidence C, there are two levels also. Weak evidence, limited data, CD, and expert opinion, which we know is often wrong, is EO. So you won't be able to read all of this, but it sort of corroborates what I have said. This is the US classification system, and I think worthy of some attention. This is the ESC, which is easier to read, not so complicated, and I think the US system is better. And the level of evidence particularly is different. So US and ESC differed in the compositions of the writing groups. And I think this is important because syncope is kind of an orphan specialty where nobody cares except the patients. And so cardiology is natural, but most cardiologists think, oh, syncope, I don't want to see this. Neurologists, it's natural, and they do want to see it, and regrettably, they frequently get it wrong. And it's also internal medicine, it's emergency medicine, it's pediatrics, it's geriatrics. So all of these specialties are involved, and I think ESC did the right thing here to be more inclusive. And the US had some emergency physicians involved, but I think no one else, as well as, of course, cardiologists. So one of the differences is in the syncope definition, which has been somewhat contentious between the two sides of the Atlantic, at least since the beginning of this millennium. And ESC published in 2009 their guidelines with a definition, and HRS didn't seem to agree with this. They have changed, but they stopped a little bit short of following what the ESC has first said. The approach is also different in that the ESC emphasizes that the clinician begins by facing a case of TLOC. It was mentioned in the last talk. And from the patient and the witness history, it deduced the condition is or is not syncope. So the patient comes with loss of consciousness. So we have to start at TLOC and move on from there. And the HRS guidelines, they mention it, but it doesn't have quite the emphasis that the ESC guidelines have. So looking at definitions, the ESC one is first here. Syncope is transient loss of consciousness due to transient global cerebral hypoperfusion. You've seen it at least twice already today. It's characterized by rapid onset, short duration, and spontaneous complete recovery. Now, those of you who don't have syncope sort of foremost in the brain, as I have, might remember that. But the US definition, syncope is a symptom that presents with an abrupt, transient, complete loss of consciousness associated with the inability to maintain postural tone. Well, who's ever seen a syncopal patient who can maintain postural tone? So that really is not necessary, although I think it hints at trying to separate from a seizure. The presumed mechanism is cerebral hyperperfusion, but we almost agree there. There should not be clinical features of other non-syncope causes of loss of consciousness, such as seizure, antecedent head trauma, or apparent loss of consciousness, pseudosyncope. So who's going to remember all that? Nobody, I suspect. Not even me. I had to look it up this morning. So for HRS, neurogenic syncope is categorized rather as a separate problem, which I think is not helpful, because all neurogenic, I mean nearly all at least, because reflexes are involved. Even in cardiac syncope, reflexes are often involved. So the potential for confusion was greatly influenced by the much quoted Framian study, Sotiriades, who have been quoted this morning in a nice way, I may say. But I would quote them in a nasty way, because they've perpetuated this confusion. In carotid sinus syndrome, there are several differences. HRS does not emphasize the necessity to reproduce symptoms of carotid sinus massage. HRS does not point out the need to perform massage in the upright position as well as supine. The method of symptoms as proposed by Brindley is not advised by HRS. This obviates by intravenous atropine the role of bradycardia in hypotension, allowing assessment of the vasodepressor component. Pacing is recommended for cardioinhibitory CSS class 2A by both ESC and HRS. So I use this illustration to introduce the second part of the ESC guidelines, which is all about how to do a test and how to interpret a test. And it includes sinus massage, tilt testing, autonomic tests, and I think this is a particular triumph of the ESC. And the illustrations are largely good and look like this. And this is an illustration of the use of atropine to reveal the vasodepressor component. So, clinical aspects. ESC provides much more, I think, than HRS in terms of diagnostic clues, and offers a separate section of a compendium of how tests should be performed and how to interpret them. So that last illustration shows you some of that. This is a completely new thing in guidelines, and the reference is below. I might add one other thing about the difference between ESC and HRS. The HRS does everything by email. Well, this is completely credible. It's a huge country, and getting people together is difficult and expensive. ESC takes an opposite view and says that we need to have the people together to discuss the contentious issues. And they're typically 3 meetings of so-called experts. And the discussions, I can tell you, have been very, very good. I've learned a lot from them. And I think the result is visible. But so in terms of risk stratification, this is a difficult issue. As yet, incompletely resolved. And there are differences here, too, between the two types of guideline. Syncope management units, I think, are not very popular in the US. I cynically suspect that the more people are admitted to hospital, the more administrators like it, and the hospital stays not bankrupt. And so syncope management units, which would help not to admit patients, are not so popular. Anyway, they don't get much credibility in the HRS, but they get a lot in the ESC guidelines. Role of EP studies are slightly more favorable in the HRS guidelines, but ESC provides more details of EP testing in bradycardias, and the value that they may have in revealing. And these were out of fashion for a long time, and maybe they're now coming back into fashion. So there are other differences. HRS is stronger on EEG recording and tilt testing than ESC, but this will probably change in Europe. I think that it has particular value in psychogenic pseudosyncope, if I may still use that title. The EEG is normal in that condition, whereas it's flat in syncope. Maybe not quite normal. It's in a way more than normal in PBS. HRS has a whole section on sarcoid heart disease, which is hardly mentioned by the ESC. It seems a bit regrettable. Early repolarization is better covered by HRS. Brugada and arrhythmogenic right ventricular cardiomyopathy, if you like. ESC recommends use of ILRs in Brugada and ARVC in lower risk cases rather than implantation of ICDs in all, as somewhat implied by HRS. This is driven by two issues well known to the ESC group: coincidence of vasovagal syncope with these two conditions is common, because vasovagal syncope is common. I mean, 40% of us will have vasovagal syncope in our lives. And so why shouldn't you have it if you have Brugada? So that's a problem which I think is somewhat better recognized by the ESC group, and avoid some ICD implantations, which can be disastrous in young people, as we know. Treatment of vasovagal syncope by beta blockers has been discussed earlier. There are differences. The HRS encourages use of metoprolol from the post-1 study, where it wasn't very strong evidence, shall we say. And ESC puts them in class 3 beta blockers. So that's really quite a big difference, and one of the larger differences that are available. Now we get to pacing, which is also different. Europeans believe that if you have frequent injurious syncope in an older person over 40, and you have an ILR recording which shows asystole, but this is reflex, then you should be paced. And the results look fairly good. They're not like pacing AV block, but they look fairly good. HRS goes into more detail than the ESC. There's a whole supplement on the topic, but it has a weaker level of recommendation. Orthostatic hypotension, HRS is stronger on water ingestion than salt, and even the last talk was about reflex syncope, but it's just as important in orthostatic hypotension. HRS recommends droxidopa, which it's not entertained by the ESC, which is a pity. Pyridostigmine is recommended to be by HRS, but not mentioned by the ESC. HRS has a section on acute dehydration, which only ESC includes by implication. Rehydration is class 1 CD from HRS, and reduction in hypotensive medication is an important aspect classified to CD. This is incompletely covered by ESC, and this is disappointing since Michele Brinilic's group, he was the leader of the ESC group, have published the Stop Vasodepression trial, which addresses recurrence of syncope after pacing. With too many hypotensive drugs being reduced, you get a better result. Other condition, POTS and syncope is somewhat glossed over by HRS, but this is likely to be due to the guidelines which were published in 2015 on POTS and reflex syncope. HRS has a whole section on uncommon conditions, which is very comprehensive and superior to the coverage offered by ESC. Syncope in athletes is well covered by HRS. Syncope in Mobitz type 1 second degree AV block is not covered in either document, but it remains a point of divergence between the two groups, with a stronger recommendation to pace from the ESC. And we have to go back to 2013 for ESC and I think 2011 for HRS. In pediatrics, surprisingly, HRS states in the syncope in pediatric patient section that single chamber pacing is acceptable. I mean, maybe in the neonate, yes, but older children still, and it seems to be against the available evidence. Our Rhythm Society section on syncope in adult congenital heart disease is much more detailed than the ESC, and I think again reflects the composition of the task force. There were no pediatric cardiologists. Oh, no, there was one in the ESC group. Driving and syncope, HRS points out the evidence of the very low risk of VVS during driving, and we have Canadians very often to thank for this, which the ESC does not do so positively. Points where ESC guidelines may be superior to those of HRS. Details of autonomic function tests, how to do them and interpret them, I've mentioned that already. Use of smartphone apps, patient video of the attack. Classification of ECG findings on ILRs, very detailed but ignored by HRS. The new aspects of tilt testing as a risk stratification tool for results of pacing therapy, not really covered by HRS. A little bit in the supplementary document. Video during tilt testing to define the moment of syncope will become very important. This could be useful to avoid pacing when syncope occurs before bradycardia or invasive vagal syncope, as Gerd van Dijk has shown. ESC covers the role of adenosine in syncope, but not so with the HRS. Points where ESC may be superior. ESC addresses the rate of syncope recurrence in different pacing indications. HRS does not cover this. ESC approaches therapy by use of a spectrum of young versus older patients. And you've seen this picture before, but I'll show it again in a moment. ESC has much greater focus on falls being likely to be caused by syncope. I think we will have a talk on this later. This is very important. ESC has a more detailed neurological diseases section, undoubtedly receiving contributions from the greater number of neurologists on the panel. 0 for HRS. So this is the diagram I was referring to, and in color it shows that the younger patients have these facets to consider, and the older patients have these facets to consider. Otherwise it's the same, but that there are, approaching the younger patient, approaching the older patient is different in this reflex syncope problem. So to conclude, neither guideline is perfect. Reading and using both is a very valuable experience. So thank you for your attention.